Nice to see you all. We're going to just make sure we're recording. And as all of you kind of come in and join, we want to welcome you to our first live rhinoplasty webinar. We appreciate you all taking the time. We're really excited to share with you and answer your questions. As most of you probably already know a little bit about Dr. Solieman and I, we're here at Beverly-Hills Profiles. We've been working together for about 12 years now. That. And we have a rhinoplasty specialty practice. We do all of our surgery together. We do about 250 rhinoplasties a year. A lot of you are coming to us because you've been thinking about rhinoplasty. You have a lot of questions. Many of you are thinking about cosmetic issues. Some of you are thinking about functional or breathing issues, coming at it from different places. Some of you may have had surgery before and are coming here to ask questions about revision. So we're happy to answer all of your questions. We're really excited to go through this journey with you and help you come to a decision to make this really exciting change and create the look that you've been thinking of for a long time. We'll get right into it.
Yeah, thank you for joining us. I know it's Monday evening. Many of you probably had a really long day already, but you know, we're ready and we can start talking. If you guys can, go ahead and chime in with any questions that you have. Dr. Litman's prepared a little talk to begin with, just to go over some initial conversation points about the differences between a primary rhinoplasty, those who haven't ever had surgery before, versus revision rhinoplasty. And he's done a fair bit of work. It's actually really neat. We're able to see patients who we saw preoperatively, what they look like, the computer imaging that we did to show them what we think that they're going to end up with, and then we have their postoperative pictures, so you can really see how closely we could match the result. And I think it's actually really an important process in communicating what we're able to do, and also for you guys to just have questions about how this is all done.
So if you have questions, if you're joining us now, you can start to put up some questions. We'll answer them as we go, or answer them right after we give a little brief presentation. You can access the questions through the little Q&A button at the bottom of your screen. For some who joined through their browser, you may not be able to get to the Q&A. So if you've done that, you have to go back and download Zoom and join through that method. And that way you can access Q&A, you can ask some questions, and we'll go right ahead and start answering them when they come up. But in the meantime, I'm going to share our screen, and we're going to talk for a minute about a couple of patients of ours that we've already operated on. So we're going to show you first a primary rhinoplasty, and then we're going to show you a revision rhinoplasty, and talk for a little bit about what their concerns were, what we had done in terms of imaging, and then what their actual result was like. So you can see how closely the imaging can match, or should match, the end result. So this is a patient of ours from just over a year ago or so. She had had a nasal trauma before. Her before picture is here on the left. Hopefully you can see me pointing to it. And the after pictures, the image picture is here on the right. And we're going to show you the image for both the front view, the three-quarter view, and the profile view for both of these patients, so you can get a sense of what the image view was and what their actual result was. So for her, you can see on the front view, her main issue was that she was crooked. You can see where she had broken her nose. The bone on the right side here was pushed in, on the left side was pushed out. And she had this sort of S-shaped deflection or deviation of her nose that was causing both a cosmetic issue and a functional breathing concern. At the same time, she felt like her tip felt a little bottom heavy. She felt a little bit rounded, a little bit hangy, a little bit too full, a little bit boxy across the base of her nose. She wanted to get a little bit of refinement, but she didn't want to be too refined. She wanted to retain some of her natural ethnicity and her natural rounding to retain a really nice soft feminine look. So on the image view, we showed the nose itself being straightened, the bridge being straightened, and the bones being corrected. The tip itself, we showed some refinement to be achieved through the tip.
Really important, when you come in and we talk about these images, we really try to be very clear with what every view allows you to see. So really important, I always try to stress with patients that when you see people in front view picture, there's no depth perception here. Whether she has a bump or not, you can't tell just based on this front view alone. So front view pictures, we really focus on just two things: straight and crooked, and then width. And so what you see with her is that she was crooked, she wanted to be straight, and then overall, at the base itself of her nasal bone, she was a little bit wide, and the tip itself felt a little boxy, so she wanted some refinement.
So we'll show you what the after view looks like. And this is, I think, only about 8 months post-op. So she's still got a little hint of swelling there, but you can see how she's really been able to nicely straighten out her nose. She was able to achieve that nice tip refinement that we had showed on the imaging. And overall, her nose just feels much less obtrusive. It feels something that's not drawing attention anymore or distracting her. She's really very, very happy with the way the front view has changed.
And she had a really fantastic result. If you look at her, she's about as close to a perfect result as we would want. She, as far as the front view, you can see she's as close to being pin straight as you could possibly want. She's got really nice tip shape and form. There's no notching. There's nothing crazy going on. Her nostrils are symmetric. She just really had a great aesthetic result. And what's really pretty about all of these results, what I try to stress with patients is, what you want to do when you look at these pictures is kind of close your eyes and open, and what you'll see in the after result is when you open your eyes, all you see is her pretty eyes, her face as a whole. You're no longer distracted by any of the things about the nose.
These are 8 months pictures, so what you might see over the next 6 months to a year is maybe perhaps just a little bit more definition through this area as time goes by. But one of the reasons we wanted to show one of these earlier results is you really do get to a result very, very quickly. In most of our patients, by 6 months, we're really seeing close to a final result. So here's her oblique view. Again, now you get a better picture of what was going on the bridge. Like Dr. Solieman was saying, you had no idea she had a bump before, but now you see on the 3/4 view that she has a dorsal hump that she wanted to take care of, at the same time as that sense of the tip wanting to be rounded and kind of roll forward and feeling a little bit of extra length to the nose itself. So on the image view, we showed shaving the bump away, smoothing out and straightening the bridge. And then we see as well the tip narrowing in definition along with lifting the tip ever so slightly. And here she is.
Yeah, so what you see on the after result, what's really great about this is, we always talk about this thing like a bump, and realistically, very few people have just a bump. What you really see is a convexity. From top to bottom, there's a sense of fullness over the top, and then the tip itself seems to hang a little bit lower than the bridge height itself, and there's a sense of aging that comes with that. What you see in her after result is just a really fantastic, straight, refined view. Fits her just classically.
And that brings on the profile. On the profile, we see that hint of convexity that's going all the way down the bridge line. Also the sense that the tip kind of feels like it's drooping forward and feels a little bit bottom heavy for her. On the image view, again, we show the bump going away, a really nice straight profile with some nice tip refinement. Oops. And here you go again, seeing the after result, where you see really virtually exactly what we had imaged, which is a nice straight profile, a slight lifting of the tip with taking away that hanging columella and achieving some nice tip refinement. So for those who are just joining or coming in a little bit late, you can ask some questions. We're saving up a few questions until right after this presentation. We have one more patient we want to review. If you look towards the bottom of the screen, there should be a Q&A section where you can sign up and answer some questions, and we'll ask them in the order they came. We'll answer them. So, Dr. Solieman, I'm going to let you, if you want to talk about.
So this is a young lady who presented with a request for revision. Very sort of different aesthetics. The last patient which you saw was a little bit thicker in her skin. The tip itself felt a fair bit more bulbous. What you see in this patient is the fracture itself is significantly worse in this patient. You see on this before picture, there really was a pretty significant fracture line in here and a C shape to the nose where the tip itself also kind of pulls over and across. One of the things that was really important for this patient was, she's relatively oval in her face. She had you'll see when you see her 3/4, she had a very sort of thin aesthetic across her front view and her 3/4 across the bridge line, and she wanted to maintain that. So we'll talk a little bit about how to do that and how you balance that with breathing functional issues.
Now, she was a revision patient. Unfortunately, she had a very bad fracture. Her previous surgeon had been unable to address this high subradix fracture in the area of the septum underneath her bones. And so as a result, the bone on the left side, when it was being repaired, kind of fell in a little bit. And she's got worsening of this C-shaped deformity that you see in this picture. And we wanted to really be able to take care of that and straighten it for her.
So here she is after. Again, what you want to see is just she's pinned straight. We were able to maintain that sense of refinement that she had through her entire nose. She wanted a very refined tip, and she got everything she really wanted. She's as straight as she can be. When we get to profile and 3/4, you'll get a sense of some of the other aesthetic details.
And for those of you who've been following Brooke, she's actually done a few kind of video diaries of really talking about her process, how she determined, going through surgery again and then her recovery. So you can take a look at our website. We have some videos where you can hear from herself, and she kind of gives through all the details.
So here again, what you basically see is she had a little bit of a bump hump thing going on. You really can't tell in this 3/4 just how badly infractured she is here. The tip itself was hanging low and down from a lack of support. We wanted to show her getting some support, having a little bit of rotation, and then straightening out and fixing out that valve collapse issue that she had going on. And here she is post-op, really almost identical with what we had imaged for her.
So these, we find these kind of examples hopefully helpful to you to really get a sense of, as you're talking to your surgeon and go through computer imaging, it's a really invaluable tool we find to being able to show our patients what's possible, what you really can expect from surgery. And when used correctly, this is not really about some fantasy notes. It's really about trying to show you exactly what's possible. And I think you can see with these results that the actual result a year later in her case gets extremely close to what we were able to image for her.
So if it's okay with you guys, we're going to turn to a couple of questions that have already been presented and see what we can answer for you.
Okay.
All right.
So we'll repeat the question because I don't think all of you can see it, and then we'll go ahead and answer. So first question is, what is the highest number of surgeries somebody has previously had before you fixed him or her? Does it happen that somebody has even 7, 8, or 9 surgeries before you fixed her or him?
That's an interesting question. We don't really like to count the number of surgeries patients have had previously. To be completely honest, there was one patient who had had 15 previous surgeries where we went back and, it was a very sort of detailed, nuanced detail for her where she had some significant notching of her nostrils that we were able to correct for her. We always tell patients it's not necessarily the number of previous surgeries that a patient has had. So if somebody can have one bad surgery where there's a significant amount of scarring, damage to the skin envelope itself, and that poses a certain number of issues and complexities. And other patients can have 3, 4 previous surgeries that, were relatively minor in what they were attempting and what they did accomplish, and there was no major complications, and as a result, it's not as big a deal. So the number of previous surgeries in and of itself is not the limiting factor for us.
And we had one patient many years ago actually who had her nose actually bitten by a pet ferret when she was a child and had I think something like 35 or more reconstructive surgeries. So again, like Dr. Solieman said, it's not the absolute number that matters, it's what was done during those surgeries. And one terrible surgery can be more devastating than a handful of surgeries that preserve structure.
Absolutely. Now we have a question about rib cartilage, also a cadaver rib question. I know a doctor in Switzerland who uses lyophilized cartilage, also known as lyocartilage. Is it the same like cadaver rib which you're using?
So not exactly the same. We use cadaver rib cartilage, which is solid rib cartilage that's taken from a tissue donor here, from a tissue bank. There are several facilities in the United States that process cadaveric cartilage. This is tissue from an organ donor, and it's treated in exactly the same way as every other donor tissue. So if you need a heart transplant, a kidney transplant, or anything else, it goes through that same screening process to make sure that there's no chance of an immune reaction, there's no chance of any kind of disease. But more than that, it's actually irradiated, which does something to the cartilage itself.
That's a really important component to what's going on with donor rib cartilage that we utilize. The radiation process itself does a couple of things. One, it tends to fix the cartilage itself and makes it a little more rigid, a little bit harder. We find that useful in the sense that when we carve out the pieces that we want, it's able to largely maintain that shape. And what the large long-term studies have shown with cadaver rib cartilage is that when you compare that to your own rib cartilage, the likelihood of getting warpage or resorption is actually a little bit less. So with your own rib cartilage, you tend to have resorption and warpage rates of close to about 3%, and with the donor rib cartilage, it's closer to 2%. With respect to the specific question of lyophilized cartilage, it's hard to sort of make a statement because the problem with a lot of these sort of other options that become available is there's no sort of big long-term studies to really evaluate what was done. I was lucky enough to have trained with one of the foremost experts in using cadaver rib cartilage. And so we were able to evaluate looking at hundreds of patients requiring thousands of grafts and really evaluating these patients over a decade and really get a sense of what is achievable, what the resorption rates were. And that was a really, really important and seminal project that I think was really important to our practice in terms of what we think is useful.
So in kind of summary, we absolutely advocate and prefer to use human implantable tissue, whether it's your own tissue or whether it's donated tissue. As Dr. Solieman said, I think he was still involved with what I think is still the largest study of donor rib cartilage. It has exceptional results over many, many years in the many hundreds of patients, thousands of grafts that they studied. Using your own rib is another option as well, and some surgeons prefer that. In our hands, we prefer the donor rib because you don't have the pain and the scar and the discomfort and some other issues associated with harvesting rib. But that said, there are many ways to get great results. The important thing is that you go to surgeons who have a tremendous amount of experience using whatever techniques they do to make sure you get the result that you're looking for.
Yeah, really important. We try not to be dogmatic. We're not the practice is going to tell you you can only use donor rib cartilage, or you can only use ear cartilage, or you can only use your own rib. We present the risk benefits of all of those options, and I think it's a really important conversation that you need to have with your surgeon to determine what's best for you.
So let's move on. If there's a concavity rather than a convexity, what are the options for correction? Great question. On a related note, what if there's not enough cartilage in the patient's nose to do what you're hoping for?
With respect to not having enough cartilage in the patient's nose to do what you're looking for, there's a lot of options there. So if the septal cartilage has previously been harvested and utilized, that's something that we see all the time in revision cases. So, again, we present the options to patients. One option typically is to use your own ear cartilage, where the incision is made in the back of the ear and you use the cartilage in the bowl of the ear. There's no change in the structure of the ear itself. There are some limitations with that. The ear cartilage itself tends to be a little bit curved, as you can imagine, because it's in the bowl of the ear. So finding a very straight piece is a little more difficult. The cartilage itself tends to be a little bit more malleable. It's not quite as rigid and strong. So in our practice, we like to use donor rib cartilage whenever it's really necessary to have an abundance of cartilage. So for somebody who's got a real saddle nose deformity, if you've been severely shortened, things like that where there's really a need for a lot of cartilage, rib cartilage that comes from a cadaver, as we just talked about, is a really great option.
So this is a situation that you face actually quite commonly. Not everyone wants to have a smaller nose. Some people have a nose that's scooped out or too small and want to have augmentation of the bridge, and that's where the rib cartilage comes in. This can be someone who's had in a revision situation where they've had a trauma or they've had too much bone or cartilage removed, or in a primary situation where patients of various ethnicities might have a low bridge and want to have their bridge augmented. The various options are important, let's be clear about one thing. There are some surgeons who prefer to use implants to augment the bridge, and we're not huge fans of implants, and we'll talk a little bit more.
Yeah, that's a little bit more of a long-term issue. The silicone implants that we see a lot of in primarily Asian patients, those tend to over time, and again, we're talking long-term, 10 years plus, you see some extrusion, meaning the implant over time presses up either against the skin or through the inside on the mucosa, and eventually causes an infection, starts to get exposed and has to be removed, which necessitates a second surgery. And let me just back up for a second, just in case we're not being very clear. The question is, what if there's a concavity rather than a convexity? So what the person's asking is, if rather than, for a lot of patients, they come in and they've got a bump and they want the bump to go away. And the question this patient's asking is, what if the opposite? What if they've been scooped out? And that's something we see a lot in men. That's one of the main sort of complications that we see, that patients who had surgery somewhere else. In men, most men do not tolerate having a break or a scoop to their nose. It's a little bit of a feminizing feature. So in a primary case, we always talk about that and really stress not doing that. In patients who've had it before, it's really interesting that oftentimes we'll see patients who've gone a lot of places and they just can't get to an answer, what it is that really bothers them. And it might be as small as a little 1 millimeter break in the nose, and you show that bump that little scoop going away, and they're satisfied, and they're like, that's exactly what I've always wanted. So yes, the rib cartilage is a great source for that we utilize. If the septal cartilage is intact and there isn't a need for a tremendous amount of height, that's an option as well.
So we took a long way around to answer that question. I hope we were able to answer that for you. The real answer is, this is very specific to your needs and whether you need 1 millimeter of augmentation or 4 or 5 millimeters. And that's a good conversation to have with your surgeon to see what options there are available. So we're going to move on to the next question. I know somebody in Iran who got a cadaver rib in the nose, but it got infected. Is the cadaver rib in the USA more sterilized and clean than in Iran? Can USA cadaver rib, which you're using, also get infected? Have you ever had a case where cadaver rib got infected?
That's a great question. The infection rates, whether you use your rib or donor rib, in the US at least, is exactly the same. It's less than 1%. It's very, very unlikely. The nose is such a vascularized region in the body that unless somebody has a break in the skin, a break in the mucosa, some sort of severe reaction, maybe a really bad breakout or anything like that.
Or maybe a collection of fluid or blood underneath the skin.
Yeah, those are the only cases or only times you would imagine that a patient can get an infection. And so it's really more external to the graft source itself. It's not because there was a donor rib versus your own rib, but rather the milieu that you put it in that tends to be the problem. So in our experience, I'll tell you that we've only seen maybe two infected cases in 12 years.
And we do a lot of this. So we use a lot of rib cartilage. So
that would be
well, we're talking many, many hundreds, if not thousands of patients.
Far less than 1%. So it's very, very unlikely. I can't speak to exactly how the donor rib cartilage is processed and handled in Iran. But from our experience here in the States, that's not a major issue.
Okay. Let's move to the next question. Hi, docs. How much notice do I need to give for the procedure if I've gone through initial assessment a year ago? Well, you don't need to give a lot of notice at all. Give us a call. You can reach Bohart tomorrow. She'll be back in the office. And she's happy to talk to you about what you're looking for in terms of scheduling. We're very happy to hear from you again, and very excited to help you create this change. So give us a call and let us know.
Yeah, one of the nice things about the practice is that we have our own surgery center, and we take a lot of pride in that and maintaining it to the utmost standards. And that allows us a lot of flexibility to take care of our patients. So we have patients, really from all over the world who kind of call, a week or 2 or 3 weeks before they fly out and say, hey, I'm going to be out there in a couple of weeks. Can you take care of me? So as long as we have a little bit of leeway there, we're largely able to accommodate people.
So for those just joining late, we're answering all your questions about rhinoplasty today. Really excited to share these questions with you. You can access the Q&A section at the bottom of the screen and ask your questions. For those who are interested in consultation, you can call our office. If you're in the LA area, come in and see us. We do offer Skype consultations because a very large number of patients in our practice are from out of state or out of country, and we are happy to offer Skype consultations to be able to answer your questions more specifically after the call.
Okay, the next question. Do nose jobs change your voice?
We're going to do a short answer on this one. The short answer is absolutely not. There's no change in your voice. We get this question primarily from singers. We practice here in Hollywood, and so a lot of our patients are in the entertainment business, whether singers, actors, performers of some kind. Many are worried that a nose job is going to change the quality or the resonance of their voices, and the answer is no. There's absolutely no change to your voice. That said, if you have significant nasal obstruction, significant breathing issues, you often can have what's called a hyponasal or a nasal sounding voice because you're not naturally moving a lot of air very well through your nose. And so correcting the breathing issue can actually allow you to retrain your breathing and breathe better through your nose and at least hold your notes a little bit longer.
So that's Dr. Lindner being short in an answer.
It's the story of my life. Next question. Why does some doctors still prefer to take a patient's own rib rather than cadaver?
Yeah, that's a really good question. We don't really have a great answer for it. I think it's largely due to just experience. A lot of plastic surgery and surgery in general tends to be an apprenticeship. So most surgeons end up doing whatever they were trained with. And so if a lot of surgeons are trained by people who are used to the idea of you got to take a patient's own rib. From our experience and from the studies looking at this, there really isn't a great answer as to why using your own rib cartilage makes a lot of sense. I mean, frankly, it's a lot more painful. You have a scar under your chest. It's not a terrible scar, but it's still a scar. If you're a woman, it's just under your breast. So most people don't want that. It hurts, for about 6 weeks. Every time you take a breath, it's going to hurt because you're literally breaking a rib to take out a chunk of rib. There's also some problems with that. As patients get older, a lot of the rib cartilage tends to calcify. So there's a real likelihood that you can, again, depending on age, that you're going to go in and go look for a rib and get in there and realize that it's calcified rib and that it's not usable. So that's an option that is not great there. Beyond that, you're talking about added surgical time. You can imagine to do this when a surgeon needs to use your own rib, they're going to go in, they're going to start the surgery, they're going to get to the point where they decide, okay, you don't have septal cartilage, you really do need rib cartilage. They have to stop, they got to go into your chest. That's going to take an hour and a half to take your rib cartilage. They got to sew that up, and then they've got to carve out that cartilage into the shapes and pieces that they require. And frankly, they just don't really have a lot of time at that point to just sit there and observe it and get a sense of, is there any warpage or any problems that are going to arise with that rib cartilage? And I think that, one of the things Dr. Litman and I have always talked about is when you talk about donor rib cartilage versus your own rib, and you see that the warpage rate in particular is lower with the donor rib cartilage by a little bit, the initial studies hypothesized that was because when you irradiate the cartilage, it tends to fix it and makes it a little more rigid. And that's probably partially true. But we also think that after, hundreds of these that we've done, that part of it has to do with the fact that when we're using donor cartilage, before you're even asleep, we can carve the cartilage into the shape we want, leave it in antibiotic solution. And then when we get to that point in the surgery when we require the cartilage, we can look at it and see if there's any hint of warpage, and if there is, we're not going to use that piece.
And that's really a poignant point because the warpage tends to happen quite quickly. So it's something that you'd see within an hour or so of carving the rib cartilage, and not needing your rib to be able to do that, we can actually carve the cartilage ahead of right immediately ahead of the surgery and look to see whether any of that cartilage is warping and just discard that piece, not use it. So I hope that answered your question.
The next question is, how many nose revisions do you do each year?
So we do roughly 250 rhinoplasties a year on average, and we'd estimate that revisions make up about 50% of our patients, and give or take year to year. And so that's, if I can do the math right, it's about 125 revisions a year. I didn't know there was going to be a quit. All right, if you do both surgeries together on revisions, does one concentrate more on the tip and the other more on the bridge?
Yeah, that's a question we're asked a lot. You know, when we're operating, it's not two cooks in the kitchen sort of concept. Ultimately, one of us is going to be the person who's going to be making the actual cut or throwing the actual stitch. Think of the other surgeon as your best friend who just happens to be, I hope you consider us world-class surgeons, who is there with your images and your goals in mind and being the surgeon's absolute worst critic. We routinely argue during the procedure, not for the sake of arguing, not from a technical point of view, but really more about the little tiny details. Is it, you know, maybe from my perspective, I'm seeing something a millimeter higher or a millimeter lower, or a little bit off one way or the other. Think of the surgeon who's observing as really being just hypercritical and making sure that everything's exactly as it should be. And one of the wonderful things about the techniques that Dr. Litman and I employ, everything is done largely through suture techniques. And what's really great about that, one of the things that we always kind of stress is there's no burning bridges. You know, once you kind of cut out cartilage, like through a closed approach, if you just go in and you take out tip cartilage or do something like that, it's gone. And you can kind of try to replace it. But with us, if you throw a stitch and it's not exactly the way you wanted it to be, you can basically take it out and do it again until it's exactly right. And so surgery has largely become a dance for the two of us, where one person's ultimately the person cutting and suturing, and the other person moving the case along and pushing it forward. That there is a little bit of a difference there when we're talking about really complicated revision cases where we're talking about donor rib cartilage, for example. One surgeon might be sort of carving out pieces, making sure everything's perfect, and looking at it once it's been in solution and making sure that it's exactly the way we want it to be. There's no signs of warpage, taking out edges and corners. The other surgeon can push along, and that allows us to save a lot of time in surgery as well.
You know, a lot of people think when you think about surgery that it's really all about the technical aspects. And that's true when you're doing your surgical training and where you're kind of first starting out in practice. But after having been in practice for 15 years and doing thousands of a particular surgery, if you're a specialist in a particular type of surgery, it's no longer about the technical issues. You've mastered the techniques, and what it really comes down to in terms of getting consistently great results is about judgment. And I think that's where the two of us really are able to elevate our performance, because we're more together than either one of us practicing separately. So that's really where it all comes down to, the details in terms of surgery.
All right, next question. Does oxygen chamber help a lot after nose surgeries to get
rid of swelling?
And do you send patients to the oxygen chamber? So they're talking about hyperbaric oxygen.
Yeah, so some patients use hyperbaric oxygen chambers for various things and believe it may be helpful with recovery. In fact, we've never really found any convincing evidence that hyperbaric oxygen is needed or in fact advised for routine healing from rhinoplasty surgery. The recovery happens to be very quick anyways. The recovery in our patients tends to be less than a week or so, and you're kind of back to feeling yourself. So we found no need for hyperbaric oxygen. That said, where that may have a place in very rare cases where you're worried about an impending vascular problem with the skin or an impending infection in those kinds of situations where you're really talking about a major reconstructive surgery where there's some skin injury concerns.
Yeah, so that's really probably the only time we really consider hyperbaric chamber. There's the occasional patient who has a dense amount of scar tissue, and to get any sort of real result, you got to go in and remove that scar tissue. and there is the potential or the possibility that you can cause some injury to the vascular or to the cutaneous envelope there.
To the skin.
To the skin itself. So if there's any concern there, maybe that would be one of the few times we would consider a hyperbaric chamber.
Okay. How do you approach a Middle Eastern male nose?
Yeah, it comes in so many different varieties. We really try not to generalize and say that every one type of culture or ethnicity or regional person is going to require this particular technique or this approach. We do find that, if we're going to talk broad generalizations for a second, the skin tends to be a little thicker. Not very thick, but a little bit thicker. The cartilage at the tip tends to be occasionally a little bit softer, but not necessarily. There's oftentimes a dorsal convexity, a bump. There's usually a fair bit of cartilage. So it really is much more, in our experience, with every ethnicity who walks through the door. We really do have we've been very blessed. We have a very multi-ethnic, multinational practice where people really come from all over the world, and we're not saying that just to kind of say that. It really is one of the great joys in our life to meet people from all over the world. And what's fantastic, I think, about that experience is that we are able to really individualize the procedure. So, there might be a Middle Eastern patient who just wants the bump to go away, but wants to maintain the length and wants to kind of feel long still. And there might be somebody who doesn't, who really wants sort of the bridge line itself to come down a fair bit more, get a little bit of tip protection, get a little bit of rotation. And so we really do try to individualize the procedure for every single patient, as opposed to sort of saying we approach everyone from any one classification in this way.
Yes. So we'll pinch ourselves, because if you look at our website, you will see a section on ethnic rhinoplasty for various ethnicities. But to be honest, like Dr. Solieman said, we try to defy categorization. We hate pigeonholing our patients into specific categories. One of the reasons we love rhinoplasty, one of the reasons it's so enjoyable for us, is that every single patient is different, both in terms of what they want done, what they need done, their own particular aesthetic, and what we're trying to achieve. So we'd encourage you to talk to surgeons and find out exactly what your particular issues are.
Okay. Have you ever rejected a nose in the past due to complexity, or the patient was not realistic with the goals?
So yeah, kind of two parts to your question. I'll talk to the first part first about complexity. There are really only a few reasons where we would tell a patient that maybe they're not a great candidate for surgery. One is if the amount of change that they're looking for is so small that we feel like going through the difficulty in the investment and recovery in another surgery is perhaps not worth it in terms of the goal. So we spend a lot of time really discussing goals and making sure that the predicted benefit of the surgery is really going to outweigh the potential risks. And if we can answer yes to that question, then it absolutely is that patient is a candidate for surgery.
So to that extent, it's not a complexity issue for the most part. I really do, credit Dr. Litman. I think starting off really 10 years ago, it brought us a lot of confidence to have each other as we went through these cases, and we've really handled just about any sort of level of complexity of case you can imagine. Foreign objects being in the nose, noses being eaten away by ferrets, previous surgeries, where people have had tons of scar tissue, cutaneous injury. We're one of the few practices in the world that really handles septal perforation repairs. So it's typically not a complexity issue. It has much more to do with realistic goals and this risk-benefit analysis. If we want to see benefit way up here and risk way under the screen.
That's his hand's way below the screen if you couldn't see it.
Way down here. So the idea is, if we can make a change and be honest with the patient and they would be happy with the goals. And that's what computer imaging is really great about, is it allows us to show them what's possible, what's a realistic expectation they can have. And if we can meet there, then yes, then we proceed forward. And if we're not, then we're very honest with patients and say, we wouldn't recommend surgery for you.
And that's where the consult comes in. It's really not Dr. Solieman or I sitting here saying, well, this is what you're going to get, and we hope you're happy with it. It's a collaboration. And a lot of the consult is spent listening to you, listening to your concerns, your goals, what you want to achieve, and making sure that we realistically can achieve that, and then being able to show you that on the computer imaging and really confer with you and make sure that that's something that's going to make you happy. That said, there are some surgical limitations. So, for example, Dr. Solieman mentioned we do a lot of septal perforation repairs. It does get to a place where perforation can be so large that it physically can't be repaired. It's just too big to repair. But even in those cases, those patients can be helped. We can stabilize and reconstruct the nose to give it support and make sure that that perforation isn't going to cause a long-term problem. So there aren't many issues where complexity really holds us back.
Okay, next question. What questions should I ask during a rhinoplasty consult?
Well, we could be here all night, but the main thing that you want to get an understanding of is one is the surgeon that you're seeing really an expert in rhinoplasty. And rhinoplasty is one of those things where the difference between a so-so result and a result that's really going to make you happy is on the order of millimeters of change. So it could be a millimeter here, a millimeter or two there, but those difference of millimeters makes all the difference in terms of a meaningful result and making you happy. So you want to make sure that this is a surgeon who does a lot of rhinoplasty in noses that are similar to yours, whether it's ethnic rhinoplasty, whether it's revision rhinoplasty, whatever your particular issues may be. You want to see a lot of actual results of patients before and after photos that have goals or that have anatomy similar to yours, so you can make sure that you are going to be happy with the kind of result that you think that the surgeon is able to deliver for you. And most importantly, it's really about trust. At the end of the day, you're entering into a relationship. You're entering into a journey with the surgeon to get you to the finish line, to get you to the goal that's going to make you happy. And you have to make sure that both pre-op, during surgery, but even more importantly, post-operatively, the surgeon is going to kind of walk hand in hand with you and make sure that you're going to be able to cross that line together and weather any potential issues that might come up down the road.
Yeah, we're going to start answering a little bit faster because
we're running out of time.
So we're going to push along. Next question: are the most complex nose revisions patients who have already rib cartilage in their nose and you need to exchange and fix it secondary rib cartilage? No, not necessarily. Sometimes that actually makes it a lot easier. Sometimes if the rib cartilage is just a little bit crooked, you're able to just take it out, shape it into the shape that you want and put it back in. Sometimes it requires new rib. But either way, that's not really the most complex. Probably the most complex are patients who have a ton of scar tissue, and we can get into that at some point.
I guess you have celebrities as well to fix. Are they more complicated to deal with than normal patients? Yes. I mean, being here where we practice, we do get a lot of patients who are celebrities who are in the entertainment industry. And we would honestly say they are normal patients. We treat every patient the exact same way, but even patients who are famous or whom you might know have just the same concerns, the same insecurities, the same worries about the surgery and the same questions that you might be having tonight. So it's really about treating each patient individually and making sure that we respect your needs and your goals and make sure we get you the best result we possibly can.
Okay, next. What's your own percentage rate? A patient needs a revision after your surgery, and if a revision is needed, does patient need to pay again? It's a good question. In our practice, I think we're unique in that we set a goal, and that's based on our computer imaging, and that's the goal we're going to accomplish. And so if we somehow fall short of that goal, then it's entirely on us to fix it at no cost to the patient. That means no cost from anesthesia, surgery center, or us. We absorb those costs because we believe that that's the promise that we made to people. From a primary nose point of view, we're talking about 1% revision rate, so you're not going to get any better than that. From a revision point of view, that's a little bit different. It really depends on the type of case that we're talking about, and that's something we can talk about in person when we meet with patients.
If traveling from out of state, how long should I expect to stay in California after surgery. So we get a lot of patients who come in from out of state, from out of country, who have surgery with us. We ideally would love you to be here the day before surgery so we can actually sit down in person. We can do a Skype consultation at a distance, but in person we're able to do a lot more. We're actually able to take photos, do computer imaging, examine your nose, and really talk through all the details of the goals. Then you'd have the surgery the next day here at our surgery center, and then we would like you to stay for 6 days after surgery, long enough to take off the cast, take out the stitches, and make sure that everything's healing well and that you're safe and ready to travel home. And traveling home at 6 days after surgery has never been a problem, even for patients who come halfway around the world.
Okay, next question. Some patients say that your own cartilage does not resorb as much as cadaver. From your experience, cadaver rib resorb after some time. Again, from our experience, whether you use donor rib, your own rib, ear cartilage, septal cartilage, any of those things have a potential for resorption. Frankly, over the last 10 years, I can't recall more than maybe 1 or 2 people who we went back and had to do anything because of resorption. And that was from a different process. That was when we used to do something closer to what was called a Turkish delight, where we would take cartilage, kind of dice it up and roll it up with alloderm and put that over the bridge. And that was something that people were trying for a while. And there was 1 or 2 people who over time had a fair bit of resorption of that. And so we stopped doing that.
It was a Turkish surgeon who originated that. So, that's why I got the name. I know a doctor in Germany who uses a diamond drill rather than a rasp to get rid of bone. Which one do you use? German doctor said the diamond drill is more efficient. Is that true? Well, any mechanized way of removing bone can be more efficient at removing bone, but at the same time, it has a lot of inherent risk associated with it, which is if it removes bone too quickly, you may overshoot. And so the surgeon may have a little bit less control over the amount of speed at which the bone is removed. We prefer rasps because we find in our hands they offer a lot more control, and depending on how fine or coarse the rasp is, we can be very controlled about exactly how we're shaping the bone.
Yeah, along the same thing, somebody asked about, do we use ultrasonic rhinoplasty? A lot of these things are, frankly, tend to be more marketing issues and things that people try to do to sort of differentiate. And, they'll do endoscopic septoplasties and laser rhinoplasty, things that really don't change anything. So for the most part, we stay tried and true with the techniques we use, and that's been a big part of our success. Do you do imaging simulation before surgery? And if so, do the results most of the time look like the simulation? Yeah, so if you were here at the very beginning of the conversation, we actually went over a couple of cases where we showed the imaging that we did, the after result. And, for the most part, I would tell you guys that honestly, most patients do better in real life than the computer imaging. We purposely try to under-image to a certain extent. And imaging by itself oftentimes has a little bit of limitation where the lines become a little rigid. You can feel a little too pointy or too round. The contours can feel a little bit off if you're being very critical, whereas in real life, you're not going to have those issues.
Okay.
We're getting down to the last one.
We have a few minutes left. We'll try to answer the last few questions. Should I stay in an aftercare facility after surgery? That really depends on your situation. For most of our patients undergoing rhinoplasty, even revision rhinoplasty, you can go straight back to either home, or if you're in the area, or to a hotel or wherever you might be staying that same night. Ideally, we like to have someone staying with you for the first 24 hours after surgery. That's not us. That's following the American Society of Anesthesia guidelines, which say that you shouldn't be operating a vehicle and you shouldn't be staying alone for 24 hours. In truth, we don't expect anything to happen. So within a couple hours after surgery, you're awake, you're conversational, you can get up and move around.
But if you're traveling by yourself, we would have you stay at an aftercare center for one night.
Only if you're traveling on your own, right?
But otherwise, you can stay with whoever you're with, and there's no requirement for 6 days. 1 day would really be more than sufficient, and after that, you're going to be fine.
And
does it make a doctor a better one if he visits all the Rhinoplasty Society meetings around the world, or better he operates the whole time?
So should you travel to meetings or spend your whole time operating?
We're biased. We like to operate. for the most, there is some value in going to some meetings and getting a sense of what's new and keeping up with journals and knowing what all the newest techniques are. That being said, with respect to rhinoplasty itself, there isn't a lot of new breakthroughs all the time. So, in our experience, and what we feel is that doing surgery is more important.
That said, there are a lot of ways to get new information. So you don't just have to attend meetings. We get a lot of information from reading journals, talking to colleagues, keeping up to date on all the latest innovations. And I think we're down to the last question. Will the webinar be recorded? Can I watch it again? Thank you for asking that. We were going to get to that at the end. So yes, the webinar is being recorded. We'll make it available. I think we'll put it up on YouTube and have it available through our site. If you would like to put in some additional questions for future webinars, we'll plan to do this again. So we're happy to take any questions you might have, or if you want to follow up after the webinar, feel free to send us an email, give us a call. You can send photos, and we're happy to discuss your specific case in a little bit more detail.
Thank you, guys. You have a great evening. Thank you all for joining us. We hope to do this again soon.
Thank you very much. Hope we answered a lot of your questions.
Have a great evening.
Have a great night.